Welcome back to Diabetic Foot Files, the podcast where wounds talk, bacteria fights back, and then salvage becomes a battlefield of science, strategy, and survival. Today's episode, we're going to talk about a heavyweight champion in modern infectious disease medicine, an antibiotic, yet again, so powerful that it's often reserved for the nastiest resistance organisms that we encounter in diabetic foot infections. What do you think I'm going to talk about? Well, it's daptomycin. So this is not your everyday antibiotic. This is an antibiotic that is called when all the other antibiotics fail. When MRSA, Lassa, vancomycin, when deep tissue infections threaten the limb, when osteomyelitis creeps into the bone, when sepsis begins knocking on the door. But what exactly is daptomycin? I remember I first heard it in residency and I was like, "Ooh, that's a cool name." Because you think vancomycin and they said daptomycin. I was like, "Ooh, what's that?" But we're going to talk about how it works, why you can't use it for pneumonia, because that's a very particular thing that you have to remember, why it doesn't does sometimes save limbs, and why it becomes dangerous if used incorrectly. So we're going to go into the microbiology, the mechanisms, the myth, the side effects, the resistant patterns, and wound care applications. And the future of it is actually quite fascinating. So, what is daptomycin? Oh, yeah, and I'm Dr. G. Yay. Okay, so daptomycin is a cyclic lipopeptide antibiotic primarily used against serious gram positive bacterial infections. It was discovered from a soil bacterium called Streptomyces roseosporus. I did my best with that. And that's right. That's one of our most advanced antibiotics, came from dirt, so it came from nature, just like penicillin came from mold. Daptomycin emerged from nature's microbial warfare of the soil. Okay, and it was developed because medicine needed stronger weapons against resistant organisms, and that's why antibiotics do so means it's such a big deal. Okay, because these bacteria do replicate fast enough to have mutations where they can survive the antibiotic and how they develop resistance. Okay, especially against MRSA, VRE, resistant streptococci, deep tissue gram-positive infections, and osteomyelitis. So why does daptomycin matter for us in diabetic foot and wound care? So diabetic foot infection crisis. In diabetic limb salvage, infections are often deep, polymicrobial, biofilm forming, ischemic, resistant, and chronic. And one of the most feared organisms that dominate is MRSA, right? MRSA stands for methicillin resistant Staphylococcus aureus. And MRSA can invade tissue rapidly, form abscesses, penetrate bone, destroy soft tissue, cause necrotizing infection, lead to sepsis, and increase amputation risk dramatically. And daptomycin became important because clinicians needed a drug that could kill resistant gram-positive organisms quickly, penetrate tissue well, work in bacteremia, assist in osteomyelitis, and provide alternatives when vancomycin fails. So how does daptomycin work? The bacterial assassin, most antibiotics, they inhibit the cell wall synthesis. They block the ribosomes and they prevent DNA replication. But daptomycin does something different. It attacks the bacterial membrane itself. So think of it like instead of it attacking the castle wall, daptomycin cuts the power supply to the entire city. So its mechanism of action, daptomycin inserts itself into the bacterial membrane in a calcium-dependent manner. So it creates membrane channels. It causes ion leakages. It actually depolarizes the membrane. It collapses the energy production and causes a rapid bacterial death. It kills the bacteria extremely fast. And this is called concentration dependent killing, meaning the higher the concentration, the more aggressive the killing is. So, one of the other fascinating aspects of daptomycin is that it requires calcium. to work properly. So without calcium, it cannot anchor effectively into the bacterial membrane. So this is one of the reasons lab testing for daptomycin, uh, daptomycin susceptibility requires proper calcium concentrations. That tiny detail changes everything. So what organisms does daptomycin cover? It has excellent coverage against MRSA, MSSA, Streptococcus species, Enterococcus species, and VRE, some strains of VRE. And what does it not cover? You have to remember this, that it's very important. Daptomycin does not cover gram negative. You kept on hearing me gram positive, right? So daptomycin does not cover gram negative. It does not cover anaerobes well. It does not cover Pseudomonas. It doesn't cover Proteus. It doesn't cover E. coli. So in diabetic foot infections, it often is combined with something like Sosin, meropenem, cefepime, and metronidazole because diabetic foot infections are very frequently polymicrobial, correct? So why can't we use this in pneumonia, for pneumonia? This is actually a famous board question in infectious disease. Daptomycin does not work in pneumonia. Why is that? Because the lung surfactant inactivates it. So the surfactant basically neutralizes the drug before it attacks the bacteria. So despite being a powerhouse elsewhere in the body, it becomes useless inside the lungs. So that's one of the most strangest yet fascinating limitations of daptomycin when it comes to antibiotic pharmacology. So daptomycin versus vancomycin. So this is like a heavyweight fight. Vancomycin versus daptomycin. I know more of us are familiar with vancomycin, right? So vancomycin is older, more widely used, requires trough monitoring, slower killing, and kidney toxicity concerns. Daptomycin is it has faster bactericidal activity. It has a once daily dosing. It's better tolerated in some patients, useful in when vancomycin fails, and but daptomycin is more expensive. So you also have to remember some MRSA, MRSA strains become less sensitive to vancomycin over time even if technically is still susceptible, the phenomenon is called MIC creep, MIC, okay? Creep. And this is when clinicians may pivot towards daptomycin. So osteomyelitis and daptomycin. So as we know, bone infection, osteomyelitis is a huge nightmare, right? So osteomyelitis in diabetic feet is devastating because bone has poor vascularity, biofilms form, okay? So when I try to explain bone infection to a patient, think of when you have a very runny, congested nose and you can see all the crust and congestion in your nose and in your throat that's happening in your bone, okay? It's this deep, dark, like cave that is infected with all this bacteria and it's like deep and slimy. So it's really hard for that to penetrate, okay? For antibiotics to penetrate that, okay? Because remember, biofilm makes it impermeable to the antibiotics, okay? And how are we going to get inside the bone, right? With the antibiotics if they have this nice biofilm formation to protect it. But let's get back to osteomyelitis and diabetic foot. The bone has poor vascularity, the biofilm has formed, necrotic tissue shields the bacteria as well, and antibiotics penetrate imperfectly because of the biofilm, right? So daptomycin becomes quite attractive because it has pretty much good tissue penetration is bactericidal, can be dosed aggressively, and works against resistant gram-positive organisms. However, no antibiotic can overcome dead bone alone, okay? So that's the thing that I need patients to understand how serious osteomyelitis is. That means that, surgical debridement matters, source control matters, vascular supply matters, offloading matters, okay? Because antibiotics alone can cannot save osteomyelitis, okay? Antibiotics alone cannot, okay? I've never heard of that before. It can't, okay? So our biofilms are slimy fortresses. Biofilms, like we said, are these bacterial communities embedded in this protective slime matrix. Inside the biofilms, the bacteria actually even communicate. Okay, it's like they have what not Wi-Fi, but I mean, what is that? Fiber optics. It's like that. They have fiber optics with their biofilm. They exchange resistant genes to each other. They slow metabolism. They hide from antibiotics. And diabetic wounds are biofilm factories. And MRSA biofilms are particularly dangerous. And the fact is that daptomycin has shown activity against some biofilm associated organisms, especially when combined with other agents. Sometimes clinicians combine daptomycin with rifampin, okay, to improve the penetration into the biofilm environments. Now, let's talk about side effects. One of the big side effects of daptomycin that people have to watch out for is muscle toxicity, myopathy, okay? So, muscle injury, okay? This is why patients on daptomycin have CPK monitoring. Creatine phosphokinase levels are checked weekly. Symptoms include if they start having muscle pain, weakness, fatigue, and cramping. Another thing they have to look out for is rhabdomyolysis, okay? Rhabdomyolysis. In severe cases, the muscle tissue can break down, kidney injury can occur. This is very rare, but still serious. Always keep that in the back of your mind when you're thinking of daptomycin. Now, another thing you have to keep in mind, statins and daptomycin. Many diabetic patients take statins, okay? And statins themselves can cause muscle injury. So combining statins with daptomycin will increase the risk of elevated CPK, rhabdomyolysis, and myopathy. And this is why some clinicians temporarily hold the patient's statins while they're on this daptomycin therapy. Another frightening complication that can occur when you're taking daptomycin is eosinophilic pneumonia. Okay? Daptomycin can actually occasionally trigger this eosinophilic pneumonia. So symptoms include fever, shortness of breath, hypoxia, and pulmonary infiltrates. Ironically, the antibiotic that can treat pneumonia can sometimes cause a lung inflammatory syndrome. I get it. Like medicine is a little weird, okay? So let's do a quick little case study. So 62-year-old diabetic patient presents with a heel ulcer, calcaneal osteomyelitis, MRSA, bacteremia, and prior vancomycin failure. The wound drains heavily, smells foul, tracks the bone. MRI shows bone destruction, deep abscess formation. The patient undergoes surgical debridement, a bone biopsy, of course, IV daptomycin therapy per ID recommendation, negative pressure wound therapy, and aggressive offloading. After 8 weeks, the inflammatory markers improve, the wound depth shrinks, and bone infection stabilizes. The bone infection is never gone. That's another thing I need patients. So once it's there unless we remove the bone, right? So limb salvage succeeds, but the key lesson is it wasn't daptomycin alone. It was because we did surgery, vascular assessment, pressure relief, glycemic control, wound care, and antibiotics altogether. Lean salvage is never a magic bullet, okay? Like a one thing magic bullet. Now, even something that's kind of serious that's emerging is daptomycin resistance, okay? Because why? Bacteria are very, very smart, okay? They were here before us. Bacteria can alter their membrane charge, they can thicken their cell walls, they can repel the drug, they can reduce membrane binding. And this is terrifying because it means that even our big guns can fail. That's why antibiotic stewardship is quite critical yet again. So, what does the future hold for daptomycin? Okay, researchers are still exploring drugs for better biofilm penetration, combination therapy, liposomal delivery systems, antiquorum sensing therapies, bacteriophages, and precision antibiotics. The war against resistant infections are evolving rapidly. So, what are clinical pearls right now that we learned about daptomycin? It comes from the soil. It's a soil bacteria. It requires calcium to function. It kills by membrane depolarization. It cannot treat pneumonia. It is rapidly bactericidal. It's often used for MRSA. It requires CPK monitoring. It can help in osteomyelitis. It's often once a day, and it's one of the strongest gram-positive antibiotics we have. So, in the end, daptomycin represents modern medicine response to bacterial evolution. As bacteria become smarter, our therapies have become stronger. So, but like I said, antibiotics alone cannot save a limb. Early detection, debridement, pressure relief, vascular optimization, glycemic control, a patient education, all are remain big pillars of limb salvage because the best infection is the one that never gets a chance to invade. Okay, so you've been listening to Diabetic Foot Files, where science meets limb salvage, where bacteria tells stories, and every toe has a testimony. It is Sunday, and until next time, protect the skin, respect the pressure, control your blood sugar, and never underestimate a small wound. And this is Dr. G. Take care of your feet because they take care of you.